Hello. This is Curtis Thompson, giving you a very delayed lecture on Chapter 24, Protozoan diseases and parasitic infections. I kept thinking this was going to be a very small chapter, and the more I got into it, the more I realized it actually is quite an important chapter, and it's actually very well written and covers the subject very well. So I recommend utilizing the Lever chapter for your studies. I did try to distill it down to a 2 pages of a Word document that will be emailed to you, and those are really the highlights of the chapter and what I see as important. And I rearranged them in what I thought the order of importance for dermatology, dermatopathology is. So the more rare things are at the very end and will be covered less. So a couple big concepts that we can take through all of these parasitic diseases is that we see most of it in the US associated with international travel and immigration. We see a fair amount from immunosuppression, especially HIV. We've learned a lot over the past several decades with HIV. We see a fair amount in military people, especially those stationed in the Middle East. Lyshmaniasis is very big in that. When we talk about bites, I laugh at the term assault, arthropod assault, and this came about a couple decades ago because many of these insects don't actually bite. They just insert the proboscis. It's really, so bite, is a connotation of, two sets of teeth. So that's the reason assault is used. The big overall histologic feature you want to see is deep eosinophils. So we see eosinophils in a lot of other things, urticaria, bullous pemphigoid, all the spongiotic dermatidides, but most of those don't cause deep eosinophils. So when you see deep eosinophils, we have a different differential. Bite arthropod is one of them. It's hard for an insect to assault superficially. They quite often it's deep, and it can also go down follicles also because of path of least resistance. So you can see perifollicular eosinophils, and it can still be from an arthropod. And then one more big concept is be careful with reactive cells and thinking that things are lymphoproliferative, and particularly CD1A Langerhans cells and CD30. These can be reactive. If you do these stains, you may see them right in the middle of very reactive bites, persistent bites, and then you get kind of stuck wondering if this is a lymphoproliferative disorder. So you have to weigh, the clinical with what you're seeing through the microscope, and then give a big pause before you start doing these immunos, because you may end up going down a pathway that you didn't want to. So to begin, scabies, I think scabetic dermatitis is our most common entity that we see. We see outbreaks of this. You think of nursing homes, elderly people living in cramped conditions. There's some kind of lore and community that we see outbreaks for a few years and then it goes away. We don't know why you can see it come and go in a community. But the clinical, just think about few mites, many mites. We used to call them many abundant mite version, often seen in immunosuppressed people. HIV is one of them, the Norwegian. But the big point is normally with in just typical run-of-the-mill scabetic dermatitis, you see very few mites. So maybe there's 5 insects on the entire body. And the point is when you start going to scrape the lesions, look for the lesions, do biopsies, your chances of seeing a mite are low. We always use the term burrows for what you want to see clinically, but really more commonly, you're going to see excoriated papules. So burrows like between the finger on the hands, don't expect to see those and think excoriated papules. And then remember that post-treatment pruritus is very common. So you can have successful treatment, but ongoing pruritus for weeks to sometimes even months afterwards. And that doesn't mean the patient still has scabies. Histopathology, when we have a case that comes in, rule out scabies, or if we suspect it, we always do levels. So this is very, very important. It's hard to find the evidence of the scabies. And the number one thing you're going to see is eggs. So as I said, few mites in most cases of scabies. So very unlikely to see the actual insect, very likely to see the eggs. And feces is always touted as one of the features, but in my experience, the patients are itchy. They have lichen simplex chronicus, and they often have dirt, exogenous dirt in the stratum corneum. And this is very difficult to tell from brown feces from the mites. So you have to hold back on using that, in my opinion. Eosinophils essentially always are there. I have seen cases where there are almost none, but these are not common. So here are excoriated papules, as you might see, some pustules, and just one point again, more than burrows. And here are the pigtails, and this is a clue that came out in 2007 from Anita Gilliam, who was at the Palo Alto Clinic, and she was a very, very great woman and dermatopathologist. I very much admired her, and she passed away very quickly from cancer a few years ago. And every time I used to see Anita at a meeting, I would tell her about this clue that she published and tell her that this really, really saved me in many, many situations. So this is the pigtail clue. You can see here's where the egg ruptured, curls up like a pigtail, and they're really easy to spot at low power. So when you're scanning levels, looking for scabies, this is really what you want to be looking for. And you might see the egg contents, but generally you don't. You see these. And the reason it's important is you can see how much they look like keratin from the stratum corneum, but they curl up. So here you can see it. And when you really get on higher power, they're very even throughout them. So the thickness of the eggshell is very even, whereas the thickness of the keratin flake in the stratum corneum is variable. That being said, that can be very hard to judge, and this curling is much more useful. So moving on to Lyshmaniasis. So there's different, the Leishmania lives in different forms, and the form we want to focus on when it's in the skin is the amastigote phase. And this is what you find inside macrophages. And the big point here, and the thing you need to know, is the kinetoplast. So there's two sources of DNA inside the Leishmania, the main nucleus and the kinetoplast, and that's what we try to see from the microscope. Very difficult to see. And here is what it looks like. So this is a macrophage, nucleus of a macrophage, the foamy cytoplasm, and it's filled with amastigote phase of Leishmania. And so here's a nucleus, and here's a kinetoplast, and that's what you're trying to see. At the standard microscopes we use at 40x, you will not see this very well. So as much as we'd like for this to be a feature, the nucleus of the Leishmania with the kinetoplast, these are very hard to appreciate with the microscopes that we use, but you need to know about it for boards. The spread is through insect, commonly called the sandfly. You just need to know that in different parts of the world, there's different insects that cause it. And this is just board food again, Phlebotomus in the old world around the Mediterranean and Africa, and then Lutzomia in the Americas. So clinically, there's three groups of presentations. There's cutaneous, mucocutaneous, and visceral. And the one you're really going to be dealing with in North America is cutaneous. And once again, these are people who've traveled, military, very common, Peace Corps. I spent a year at the Lab of Tropical Diseases at the NIH, took a year off medical school, and I worked with Trypanosoma cruzi and Leishmaniasis, and all of the Peace Corps volunteers who had tropical diseases were treated at the NIH. And at one point we had 25% of all the Peace Corps volunteers from the country of Niger in Central Africa there receiving treatment for Leishmaniasis. So it's very, very common. Typically, papule nodule grows for 1 to 3 months and then ulcerates, will resolve on its own with scarring quite often. There is a pseudo-lepromatous presentation that you need to know about, where you get infiltrated plaques around the bug site that have more to do with the granulomatous response to the Leishmaniasis. And then just know that there's every single variant and site of Leishmaniasis ever reported. So the board answer is all of the above, but periungual, acral, lip, it's wherever the bug bites you that you can see this. And one recent case a couple of years ago that we had here in Portland was a patient who went to southern France near the Mediterranean Sea, watched the insect bite his arm and then grew the nodule there. So this is most of the Leishmaniasis you're going to be dealing with. But you can see it's Middle East and then also South America. So you can see it coming from anywhere. So mucocutaneous, also called espundia, is typically South America. It starts with cutaneous Leishmaniasis, and months to years develops into a mucocutaneous nasal bleeding, septal, sometimes on the ear. And then visceral Kala-Azar, we see this also once again around the world, Brazil and also in India, mostly in India. Very little skin involvement. And the skin involvement, when you do see it, is typically not directly from the Leishmaniasis. So more darkening of skin, and then also a malar rash has been reported. And then the one you need to know about is after treatment, you can get a it's called post-Kala-Azar dermal Leishmaniasis, PKDL, and it's mostly a treatment-related response. I've never seen this. So diagnostics, the old test you should know about, injection of Leishmanin antigen, and this is called the Montenegro test. Really not used anymore, but I wouldn't be surprised if you ended up in rural areas. Culture in media can be done in inoculation of animals. This is mostly for research reasons and historic reasons. And then we've moved now to PCR as the primary use. And this has really moved to focus of where we PCR speciation correlates with disease manifestation. So you can have with different species, you can tell which one is more likely to progress to visceral or not, and this can impact the treatment. And here the CDC is an amazing resource. They have clinicians with expertise in Leishmaniasis, dermatologists, and also pathologists with expertise. They perform the PCR test for free, and they also release medications like Pentostam for you to use. So it's important to utilize this resource. You can actually talk to the people, email, and they're very likely to definitively call things. Often Leishmaniasis is not considered as a diagnosis until after the biopsy is done, and then you have a paraffin block, and you can do the PCR on the paraffin block, which is pretty much what we've done 100% of the time. I would encourage you when in treatment to consider and talk to the clinicians of what to do with Pentostam if they send it to you. And then I am a big proponent of just excising the lesion rather than watching it. If you've got all the trouble of biopsying it, they've come in, if it's not terribly large, why not just excise the local organisms that are still there. But you can also discuss actually directly injecting the drug into the lesions of the patient rather than using it systemically. So suggested patterns of Leishmania presentation. I think this is from Omar Sangueza. Suggested this is histopathology, edematous, granulomatous and necrotizing granulomatous. And once again, I showed you the macrophage containing these 2 to 4 micron organisms. You may not find the organisms in all cases. And historically, everyone touts using the Giemsa stain for this. My personal opinion is you can see them just as well on the H&E as on the Giemsa. And there's really no other, I mean, a lot of special stains will highlight them, but H&Es are quite good for this. So you just see a typical mixed infiltrate, histiocytes, where they're located, lymphocytes, maybe plasma cells, eosinophils, maybe, and then neutrophils if it's ulcerated. So when you get into the necrotizing granulomatous or ulcerated lesions, you may see neutrophils. So there's really not any specific histopathology other than in general, it's more granulomatous. So there are simulants of Leishmania, and the big one is Histoplasma capsulatum. It's become much easier now with PCR and culture to tell the difference. This was an issue early in the AIDS epidemic when we saw immunosuppressed people coming in with both Leishmaniasis and histoplasma, which could be disseminated. Patients with histoplasma usually have a history of having lived in a place where, in the Midwest, where the fungus is present. And Leishmania, you may or may not get the history of travel. And then a big one, and I have not been able to get you to get a example for this lecture, and I could not find one on the web, is the silver nitrate that's used for hemostasis after a biopsy is picked up by the macrophages in the biopsy site, and it's almost a histologically perfect simulant of Leishmaniasis. So you need to know about this. And every few years, we'll get a consult of a re-excision of a basal cell, rule out Leishmaniasis in somebody who's trying to read the slide. So lesser simulants, just other infections, and then granulomatous processes, which can be infectious or not, rosacea, sarcoid, other granulomatous processes can be a simulant. So here's the big one, Leishmania versus histoplasma. You can appreciate here how similar they look. We have macrophages, which have them cytoplasmic. Look, you can even, if you start looking at the specific organisms, they look very similar. And here you can see how hard it is to appreciate the kinetoplast on the Leishmaniasis. So which one is Leishmaniasis and which one is histoplasma? The one clue I can tell you is that histoplasma tends to fill the whole macrophage. Leishmania more commonly, I don't know how well it's demonstrated here, lines the outside of the macrophage cytoplasm. That's just a soft clue. So here we have Leishmaniasis and histoplasma. So moving on, Meiosis, this is something we see not uncommonly in travelers. You have the larva and the fly, and just know that the human is an accidental host here. Little history, the term Meiosis comes from the Greek word fly, Maia. Different flies in the Americas, Dermatobia Hominis is the most common. Typically, this can occur in a wound site. It can be furuncular, and then there are variants, I've never seen this, of creeping, where you see actually moving, and we have other creeping entities and parasites. So in the biopsy, just know the biopsy can miss the larva. We have the whole, if it's suspected clinically, if you see it, you can occlude the site so the larva can't breathe, basically, and it will come out. The old thing was to put bacon on it. You can just put Vaseline, and often the larva will come out. Can be difficult to get out if it doesn't come out itself, and then you may not see it on the biopsy. So I've seen biopsies where you just see a mass of eosinophils, superficial and deep, subcutaneous, and then you don't find it, and you instruct the clinician to go back and look, and the larva is still in the patient. We here in the Portland seems to be common. Travelers to Costa Rica is a common clinical presentation. So here's a cross section of the bug when you get it, and just know you have like legs, intestines, all the different parts, chitin. We have the chitin core of or outer shell of the insect. So you'll, depending on where it's sectioned, you'll see different components. So amoebiasis, there's two broad categories, and this is the entamoeba, and then the other three you can group together as freshwater amoeba. And this is important to understand. The entamoeba comes from within you, so it's GI extension, typical perianal genital fistulas, and the others are obtained from freshwater. So Southeast United States, swimming in fresh water. You see it in hot springs. When I was a resident at UCSF, we had an autopsy on a patient who went on a green tortoise tour. I don't know if any of you have ever heard of this. It was a really low budget tour group that took school buses and took the chairs out of them and put mattresses in, and then they went all over the Western US. I think they still exist, but person went on a tour of hot springs in the West and got the Naegleria, where, you know, fresh water comes up your nose, gets in your brain, essentially always lethal. So anyway, this is what we're dealing with. 3 different amoeba types you need to know about. And you can see pustules. There's a sporotrichoid spread that can occur. And then know that there can be vasculitic presentations. And this is probably from direct infection of cells by the amoeba or disease of the spread within vessels. There is immunohistochemical identification at the CDC, and I would encourage you once again to just remember this, and just in general remember that the CDC can be a good resource for different parasitic considerations. So here's what you see, and when you first look at this, you think these are just foamy macrophages, and they're actually the amoeba. So they can be a little bit hard to see. This is certainly something that could show up on a board exam, but you see it looks like a macrophage, and then it'll often have this kind of like thing that looks like a nucleolus in it, but it's just a little bit too big and a little bit too red, purple. So it's a little bit different. It's just not quite right for a macrophage with a nucleus and then this large, and macrophages can have nucleoli, but not this big. And so this is actually just a pause and you can start seeing them. This is a biopsy from the GI tract. I didn't have a good one from the skin. And then the thing that you would like to know for the boards is that they can have erythrocytes within them. So this is a big feature that is always touted. You can see the amoeba here, and it has some erythrocytes within it. Cutaneous larva migrans. Typically with this, I think about, so you have this organism crawling through the stratum corneum. Most cases typically picked up, I think of the beach in Copacabana, Brazil, where people walk their dogs who have tapeworm, take their dogs to the beach. And so the sand is contaminated from the dogs. And then people sit on the beach and acquire these. And one thing that happens is people try to kill the migrating organism, but you can't really find it because it's very small. You can see, look, here's a keratinocyte, here's a cross section, and it's actually ahead of where the actual clinical lesion is. So this is all just reaction to it, and it's beyond that. So if they're trying to find the end of it and kill it, it can be quite difficult. Strangeloidiasis is a similar, so this is kind of a cutaneous larva migrans simulant. Isn't quite as like right and left turns geometric as this. It tends to be more straight, and it looks urticarial. And so why does it look this way? Well, the worm, it's larger, but it's deeper. So it's not in the stratum corneum. So where you're seeing the urticarial reaction is more superficial. So if you do a biopsy, you'll just see urticaria. It's usually a single worm, and this is the larva migrans variant serpiginous. So you won't see the worm, but there are disseminated variants of this where you can find the worms. I've never seen a case. Filariasis, what you need to know here is you have it's dog heartworm. Heartworm is the most common thing we see. We know it's spread by mosquitoes. So you have an infected mosquito and the human is the accidental host. So you see the worms at the site of the mosquito bite. So here we have this in the community, dogs, raccoons bite there, and you see it where the site was. So it's typically a bug bite site, and then there will be a larva somewhere around there. Swimmer's itch, this is something that can show up, schistosomiasis. There's different schistosomiasis presentation, but this is the most important for dermatology. And just here's what happens is water temperature grows up, snails reproduce. So here's where the source of it is, schistosomiasis. Problems around the world, China, Brazil, you can have it in different areas. Migrating aquatic birds come there. So there's this whole snail bird thing going on, and then people go out swimming and you pick up these larvae. So it's mostly an urticarial reaction, and it's really tied to the history of having swum in warm water in certain locations. Cystic Sarcosis is what we think about with pork, infected, undercooked pork. It still occurs, can occur anywhere in the body, and it does occur. I've never seen a case of this, but can cause calcified lumps in the skin. Here's an example I found, and just think of calcium, and then you can see something's not right with this. One thing that's good to think about when you're looking at or considering a parasite is, does it look like any normal structure that's in the skin, or does it look like something from somewhere else? So one big thing is the chitin associated with the organisms. You can often find that, and then so it's just a matter of figuring out whether you think this is something different that doesn't occur in the skin. Keep in mind that there are simulants, like I showed you the silver nitrate. There's other stimulants that can make things look like parasites, but are actually not. Onchocerciasis, just think about river blindness. I'm not going to get too much into this, but one thing to know is you can see the worm actually in the sclera of the eye, or in the mucosa of the eye, and then it's large enough for you to see histopathologically. So one of the things you have to think about when you're looking for these different organisms is what is their size, and does it match up to what you're seeing through the microscope. So pause, and if you're going down some differential pathway that it may or may not be making sense, you can help solve it by thinking about the size of the organism that you're looking for. So to conclude, I want to just show you a case that came here. We had a 63-year-old female here from Portland, Oregon. She traveled to Africa to see her daughter, who was serving in the Peace Corps, and wore open sandals. So she came back, had a lesion on her right toenail, and it came in as rule out squamous cell carcinoma. I did not get the history of travel to Africa at the start, just simply the rule out squamous cell carcinoma. So here you can see something. Here's you can see keratin here. And then beyond that, you can't see very much that looks humanoid. So here you start to see the outer layer of this entity, all this internal complicated material, which is organelles. And here's so this is nail plate or keratin here. And then this is this very odd looking thing that is just a degenerated chitinous outer shell to this organism. So this is Tungiasis. These are internal organelles of some sort. I've highlighted them. It's a Keemsora trichome stain, I can't remember. But that's one of the other things in here. One of the big differentials would be, is this just something exogenous that's not an organism? We see a lot of plant material in nails and on fingers. So that is one of the things in the differential. This was just too large. And when you have plant material, you usually see the cell walls. So you'll see the nice little squared off cell walls there. And we don't see that here. So it's a Tungiasis. So what is this? It's a pregnant sand flea. Just keep in mind, there's different sand. There's sand flies, there's sand fleas. These are common names that are used around the world for different organisms. And here we're talking about this specific insect, Tungia penetrans. So it crawls into feed, sad to say, under a toenail or somewhere, and then it lays its eggs there. So probably these are eggs from the organism. So there you go. So anyway, thank you very much for our opportunity to give this lecture. It was a nice education review for me also. If you have any questions, this is my email that I use. Come to Portland. We have residents rotating through our lab here and a lab in Michigan also with our group there. So things are opening back up, and happy to have you come and spend rubber rotation with us and enjoy the Pacific Northwest. Thank you very much.